Saturday?
Yun lahat.
Lahat.
Are we complete?
No doubt, not yet.
Okay, let's wait for a while.
Excuse me, Doc. I think a few students are waiting to be let in.
Okay, are we complete?
Doc, four more students.
Just two students. Can you please call them so we could start?
Yes, ma'am.
When was your lecture on dystocia?
It was last week, I think.
Last week. Yeah, our topics for this week, the lectures are
Doc, diabetes in pregnancy and abruptio placenta.
okay. So when would you like your SGD on those topics? Monday and Wednesday.
Whenever
Monday. Would you like Monday and Wednesday next week again? That's fine. Okay.
Yes, Doc, that's fine.
So it will give you time to study on the topic, right? Who are the two that is still waiting? Who's still not
Ma'am, there are
here?
four who haven't joined yet.
We'll wait a bit. Okay, here's the two people. Okay, I think we could start once they get admitted. Hey, could you open your camera? We'll document it first so that you have proof and I have proof that we conducted class. Okay, could you print screen Abhishek and send it to me?
Yes, ma'am.
Okay, 1, 2, 3, smile.
Ma'am, two more students haven't joined yet.
Two more. All right. Call them so we could start. Oh.
Yes, ma'am. Message them.
Okay, I think let's they'll just catch up. They'll have the picture at the end. Okay. So
Okay.
for this afternoon, we will have dystocia. So what is your understanding of dystocia?
Shoulder is arrested.
So it is arrest in the
Shoulder.
labor or abnormality in the progress of labor in a patient, thereby necessary further intervention, usually cesarean section, and it usually leads to cesarean section. So what may be the different reasons why a person will undergo or will experience dystocia?
Doc, there may be abnormalities in power, passenger, or the passage.
Okay. It's abnormality in power. What's the other? Passage
Passenger and
and
passage.
passenger. Okay. What could go wrong as far as power is concerned?
Doc, inadequate contractions or inadequate force pushed by the mother.
Okay. So it would be inadequate uterine contractions, thereby causing problems in the expulsive forces of the uterus on the fetus. That's correct. So, what are the factors that may affect power? What are the etiology of power problems as far as dystocia is concerned?
Epidural might reduce power.
Epidural is one, that's correct. What else?
Doc, hypotonic uterus.
A hypotonic uterus. What could cause a hypotonic uterus?
Ma'am, decrease in number of contraction and strength causes hypotonic.
Oh, let me rephrase the question. What are the conditions that might affect that might produce a hypotonic uterus or affect the uterine contractility? What could cause your uterus to contract properly? So think of various conditions, factors in the mother that may affect uterine.
Hormonal problems.
What are the problems? That's what I'm
Ma'am,
asking.
Oxytocin, less oxytocin.
oxytocin or progesterone.
What will oxytocin or progesterone do?
Oxytocin.
Progesterone.
Wouldn't oxytocin make your uterine contractions more adequate? You give oxytocin if there is inadequate power, inadequate contractions. So what would be causing those inadequate contractions then?
Doc, epidurals.
Okay, initiation of epidural may have lacks in power. That's correct. What else? Think of your pathophysiologies.
Ma'am, choreo, sorry.
Chorioamnionitis or as simple as any infection would cause inadequate powers. How would infection bring about inadequate contractions? That's correct.
Ma'am, it might increase the contractions.
It might increase. Would it increase?
Increase in contractions.
There may be increase or in contractions, but because of infection, your tissues are not really at its optimal state. Even if there are contractions, it is inadequate. Okay. Infection is one. What could be another explanation for inadequate contractions?
Ma'am, the position of the mother.
How would position affect contractions?
The uterus contracts more frequently but with less intensity when the mother is lying on her back.
Okay, could be because the mother feels the contractions more. What else? What else could affect contractility?
Ma'am, prematurity.
Prematurity?
Ma'am, not sure, but the size of the uterus.
Size of the uterus? If it's small or over distended, is that it? You think?
Bruised uterus.
If it's the uterus, what could cause infection is one, the structure. Okay. What could grow on the uterus that might impede on contractility?
Ma'am, prior cesarean deliveries.
Prior cesarean deliveries, you don't want the uterus to contract so much in previous cesarean deliveries, but they still have the ability to contract. You think, you know
Doctor,
that,
Biconvex uterus.
endometritis.
what?
Biconvex uterus.
Okay, um, anatomic abnormalities, that's correct. So one is your bicornuate uterus. Okay, your uterus would have two horns, thereby it would not contract synchronously. That's correct. What other anatomic structures could cause difficulty or inadequate contractions? You're on the right track.
Uterine polyps.
Uterine.
Fibroids.
Yes. Okay. Your myoma, uterine fibroids, especially if it's found at
Intramural.
well, actually anywhere, and it has a significant size, affects your powers or your ability to contract substantially. Okay. So remember that at least the infection, anatomic structures that affect power. Okay. Passenger. What about the passenger would make it difficult for the patient, for the mother to deliver vaginally?
Gigantism.
Large fetus.
Okay, if we have a large for gestational age baby, what would be the cutoff for the average weight of a baby?
4
Or
kgs.
if it's diabetic, 4. If it's non-diabetic, you could go as high as
4.5.
4.5. Why the difference? What is present in the diabetic mother that is not present in the normal population mothers? What are we wary of?
Macrosomia.
Macrosomia. How will you describe a gestational diabetes mellitus baby? And we are more wary of this to deliver them vaginally because of what? What's the problem with the diabetes mellitus baby? Anyone?
Ma'am, there might be any injuries
Okay.
while vaginal delivery.
What injuries are highly possible in these cases in a diabetic mother?
Shoulder dislocation.
Okay. Why would shoulder dystocia be a problem in diabetic mothers or diabetic babies? Why is it the shoulders?
The baby size will be bigger rather
Aside
than
from the size,
The shoulders of the baby get stuck at the pelvic
the
brim.
shoulders get stuck because
The baby may be in transversal position.
Because of position of the fetus also, ma'am.
we'll get to the position of the fetus later. The baby gets injured because of shoulder dystocia because there is predilection of fat deposits on your shoulders, thereby producing your shoulder dystocia. Okay. That's one, a macrosomic baby. What are the others that will affect your passenger? Your classmate mentioned position of the baby. What is your position? How does position affect your vaginal delivery? So
Doc,
this
if the
happens quite often when the baby is not so large, 2'6", 2'8", but was not able to be delivered vaginally. So what was the problem? What do you look at?
doc, the transverse lie is not delivered vaginally.
Okay, the position. Of course, if it's a transverse lie, you will not be able to deliver vaginally. Okay. What else?
Ma'am,
It's cephalic.
asynchronism.
Presentation po.
It's cephalic in presentation, but still did not come out.
The face
Asynchronism.
presentation or the brow presentation.
Okay, what else? 2628, you saw that it did not come out. What will you look for?
Presenting part of the fetus.
Okay, what will you look at the presenting part of the fetus?
The diameters of head,
The fetus head, ma'am.
Okay, what in particular about the fetal head?
Asyncretism, ma'am.
Okay, what is the concept of asyncretism? You're on the right track. What is asyncretism?
Ma'am, the head presents first, but the shoulders are tilted.
Again. What's the definition of asyncretism?
The head of the baby presents first, but the shoulders are tilted, and so the baby
Shoulders?
cannot come out.
Is it the shoulders that are tilted?
Ma'am, the sagittal suture is either deviated towards the sacrum or the pubic
Okay.
symphysis.
So it could either be posterior asyncretism or anterior asyncretism. Your head is tilted either towards the pubis or to the promontory. Okay, that's correct. Okay, so when you deliver the baby, you look at your caput. Where is it? So that you will know if it's as anterior or posterior asyncretism. So you might get it backwards. Anterior asyncretism points to where?
The sacral promontory.
Yeah,
Anterior, if it's anterior asyncretism, it points towards your sacral promontory. If it's posterior, it points to your pubis. Most are often confused with that. Okay. So that is your passenger. Okay, what's the last component of dystocia?
Passages.
Passage.
Okay. Your passage consists of what? Where is the problem?
Mother's pelvis.
Okay. It's balik na. Okay. So your passage, so it could be a mid-plane problem. If it's the mid-plane problem, what are the possible sources of your mid-plane contraction?
The ischial spines may be prominent.
Hello, ma'am.
Yes.
Excuse me. Actually, I have no electricity at home, so it's late.
Who?
Joined. Goyan Ishan Kumar.
Okay.
Okay. Thank you, ma'am.
So what are we've had this our last SGD. What are the components of your mid-plane? It is just asked differently.
Convergent side.
Ischial diameter.
Okay. Your ischial spine should be divergent, not convergent. What else?
Concavity of the
Notch.
sacrum.
Your um curvature should be well curved. Okay, that's another. What else? It should
Mom, the
Sacrosciatic
ischial
notch
spines.
should be wide.
okay, your sacrosciatic knot admits 2 to 3 finger breadths. What else?
Mom, the ischial spines should not be prominent.
Okay, but already mentioned. What's the last one?
The side walls of the
Side
pelvis
walls
should be divergent.
should not be parallel or not be convergent. So that's your midplane. If it's an outlet, inlet contraction, what's the problem?
Diagonal conjugate.
Conjugate.
Okay, you are able, your diagonal conjugate. Okay, so your it's contracted if it's less than how many?
11.5.
11.55 semi, ma'am.
Okay. And your outlet, what are your components of your outlet? Although most often your outlet would not occur alone. So usually your inlet and midplane would be the problem clinically.
Bituberous diameter less than 8.
Okay, what else?
The subpubic angle less than 90 degrees.
90 degrees, what else? And the last one
Movable
is
coccyx.
your
Coccyx.
coccyx. Okay, so that is your passage. Okay, so knowing these components when you see your patient during labor, you should know and what are the disorders that you know as far as dystocia is concerned. In the latent phase, what are the disorders?
Prolongation disorders.
Okay, what are your prolongation disorders?
Along the latent phase.
What? You have your
Long
arrest
latent phase,
disorder.
ma'am.
You have your arrest disorders and your descent disorders. Okay. So for example, you admit the patient at 5 centimeters. Okay. After 3 hours with adequate uterine contractions, the patient is still 5 centimeters. What is the dystocia disorder?
Secondary arrest of dilatation.
Arrest? Why is it secondary? It's arrest of cervical dilatation. Okay, why? What's the definition of your arrest in cervical dilatation?
No change in dilatation for greater than 2 hours.
Okay, so there's no change of dilation for 2 hours with adequate uterine contractions. So, what is your plan of action then? You could do cesarean section. Okay. So, for example, you have a patient that is 8 centimeters dilation. After 2 hours, reach 10 centimeters at station 0. Then after 2 hours, patient is still station 0. What kind of arrest disorder is that?
Failure of descent.
Okay, so it's
Failure of descent.
Of descent. Okay. For example, patient reach +1, and then after 2 hours, it is still +1. What is your arrest disorder?
Arrest of descent.
Arrest of descent.
Rest of disorder.
Rest of descent.
So, as long as it does not pass your ACEs, your superior ischal spines, okay, that is failure of descent. Okay. Once it passes, then only will it be called arrest of descent. All right, is that clear? Okay, I've sent a, do you know how to do a partogram?
Yes, po.
Yes, po.
So
Yes,
what
po.
would the X represent?
The
Dilatation.
cervical
Our
dilatation
Station.
on the left.
Dilatation.
Dilatation.
Dilations, ma'am.
And the circle would represent what?
station.
Station. Okay, so that would be your arrest of descent. Okay. With anesthesia or your epidural, what happens to the waiting period? Is it elongated or is it shortened? Can we wait a little longer, or can we wait, or do we have a shorter time frame in which we have to take action?
Doc, we have to wait a little longer.
Okay, with epidural anesthesia, we have the leeway, I'm sorry, to wait a little longer. That's correct. So you know how to plot these things. So in your exam, you have to know how to interpret your partogram. Okay? So, any question on dystocia?
No doubt.
Okay, could we have documentation? Open your
Yes, ma'am.
cameras and have a print screen. Then send it to me, Abhishek.
Yes, ma'am.
1, 2, 3. Look at the camera. Okay. Thank you. Okay, so if there are no more questions, you may leave this call.